So we're back here, chapter 24, fluid and electrolyte homeostasis and imbalances. This is Barbara Garcia for Path 370. All right, so remember, it's all about your acid-base buffering system. That is going to really help your blood maintain homeostasis. Remember, that is the acid-base buffer in the blood. We have other acid-base buffers intracellularly that are going to maintain the inside of the cell's pH. Remember, all of that is about maintaining homeostasis. All right, so, the body fluids flow in your arteries, veins, and lymph vessels, and you have particular compartments that are going to need to move fluid in and out of, okay, including the cell, other joint spaces like the synovial fluid, your cerebrospinal fluid, and other fluids throughout your body. All of those need to be kept in balance, right? Obviously including the blood and so on, right? So what are the functions of body fluids? Well, they lubricate and they provide the solvent for a lot of our chemical reactions. So chemical reactions may require some type of, vitamin, or they may require an enzyme. They may require a cofactor. You have to know what all of those things are going to be useful for, especially in looking at a laboratory result, like a complete blood count and other lab results, and to know if the patient has too much sodium or too little calcium, right? So we call that hypernatremia for too much sodium, hyponatremia for too little sodium, or hypercalcemia for too much calcium, and hypocalcemia. So you have to instinctually know what that means for your patient, okay? Because you probably will be receiving the lab reports before the doctor has had a chance to look at them. And so if there's something going on, you might need to report it to the doctor, right? So you have all other things like oxygen, carbon dioxide, right? So oxygen has to enter your body, carbon dioxide has to leave, right? Your nutrients and chemical messengers like your neurotransmitters, right? And hormones, right? And then waste products. Of course, everybody has to get to their destination. And then obviously it's very important in regulating body temperature, right? So we, circulate between our, different body parts. And if it's very hot, we're going to sweat. And so we need to excrete basically fluid, right, from our blood in order to make fluid that's going to cool us off. Okay, so sweat is derived from your blood. All right, so some abnormalities in body fluid, right? If you have too much volume, hypervolemia, or too little volume, hypovolemia, these things can be problematic, right? So too much volume in your blood, for example, could lead you to edema, okay? So there's more fluid push out into your capillaries from the arterial side. So you might have to lower, and your homeostatic mechanisms are going to cause you to have a diuresis, right? You're going to have maybe a polyuria, right? So you're going to excrete a lot of urine in order to get your blood volume back down to where it needs to be, right? So concentration, right? Concentration is very important. It's going to be usually measured in osmoles or milliequivalents, or you might even see it in milliosmoles. And so concentration of different things. So milliequivalents is usually used for electrolytes, right? And any of those concentrations, even the concentration of your body fluids themselves, is very important to maintain at a very specific set point, right? So again, it's all about homeostatic balance of those things. Yes, so electrolyte composition, right? Too much or too little, right? All of these things can cause clinical problems. Some of them so severe that they could even cause death, right? Many fluid and electrolyte imbalances have something to do with pathophysiological conditions. And so basically they are part of the diagnostic criteria for certain pathophysiological conditions. They also could be as a repercussion of medication, right? So they're iatrogenic. So it's really important to know what some of these things mean, okay? So remember, at the end of the day, you're not going to be the one diagnosing a patient, but you need to know this is very severe and this needs to be taken care of immediately. All right, so body fluid, right? So, right, pertains basically to the water within the body and then the particles that are dissolved in it, right? So we have two major body fluid compartments, the extracellular fluid, which is about a third of our body fluid, and intracellular fluid is the fluid found inside of our cells. Infants have more extracellular fluid when compared to intracellular fluid than adults do. And that's important to keep in mind so that children's bodies don't adapt as quickly to changes in blood volume as do adult bodies. So adult bodies are maybe, it's better to say they're more resistant than children's bodies. So children's, they are going to have much more severe consequences of, for example, a higher body temperature for many reasons, but that's one of them, that they lose too much fluid, right? So diarrhea is much worse for them because they have less of their fluid intracellularly. All right, so the other compartments, interstitial compartment. The interstitial compartment, I want you to think of it as like tissue fluid, yes? So it's between the cells, not inside the cell. It's between the cells. Vascular compartment is located inside the blood vessels. So these are all extracellular fluids, right? They're not inside. So other fluids like GI fluid, cerebrospinal fluid, synovial fluid, and then any type of fluid within our connective tissues and bones are extracellular fluid. Right, total body water, right, in all of our fluids, right? So it's the total amount of water in all of our compartments. So the percentage of body water is varies according to a person's age, a proportion of body fat in infants, in men and in women, right? So a liter of body water weighs about 2.2 pounds or about 1 kilogram. Right, so our fluid homeostasis is our dynamic process that results from the four things that I mentioned here, right? Fluid intake, so what you consume, absorption of what you consume, distribution of that is absorbed, and then excretion. So usually what will occur is that you'll have a dynamic balance between what you intake and what you excrete. Right? So you could see there, fluid intake, right, is going to be then excreted possibly through the skin, through the lungs, okay? Your fluid absorption is going to occur in your intestines. You might see fluid excretion, obviously, through your urinary system, so there's a little kidney, or through your digestive tract, and then fluid distribution within the cells and tissues, okay? You could also have fluid loss through some abnormal routes, right? And that's through, for example, drainage, or fluid intake through some abnormal routes, such as like a patient who needs to be rehydrated with what we call a banana bag, right? Those are going to be isotonic saline, which is 0.85% NaCl. It's the same concentration that it should be in our plasma. Okay, fluid intake usually is fluid into the body by any route, right? And then increased concentration of extracellular fluids, which is measured in osmolality, right? Decreased circulating blood volume. So, for example, those changes can trigger thirst, right? So, in older adults, even though you might have thirst, you might be able to ignore that signal. Okay, so as a child, you might have a harder time with that, and that's why maybe babies might cry, children might ask for water, but as you get older, you're like, all of these other things take over. And so you stop asking for water or even listening to that thirst desire, unless it's really, really bad, which means that you're probably very, very dehydrated, right? Other possible routes of intake, right? Intravenous intake, like mentioned in that picture, rectal intake by, for example, enemas, right? Subcutaneous tissue or bone marrow infusion, and other intake tubes into the GI tract and other body cavities. Right, so which primary stimulus for the sensation of thirst declines with aging? Right, so remember that we were talking about was increased serum osmolality being what we do not detect the older we get. All right, fluid distribution. Right, so the capillary forces, right, that are going to play into your movement of fluid. All right, so there's a really good picture, this one, which is located on page 520, this figure 24.1. It is really important you understand the compartments that are mentioned here, okay, because all of these are going to aid in the distribution of fluids throughout the body. All right, so one of the main movements of fluid is your capillary hydrostatic pressure. And what is that? That is the outward push of fluids in the blood against the capillary walls. So I want you to think of a capillary, right? The capillary system that you're thinking of has an arterial end and it has a venous end. I had mentioned this before. On the arterial side, you're going to have certain forces. And one of those forces that you're going to have on the arterial side is you're going to have the blood pressure. That's what we're talking about. Capillary hydrostatic pressure is blood pressure. So that blood pressure is on the arterial side of your capillary is pushing stuff to be delivered into your tissue. Yes? So that's the outward push, right? And then the interstitial fluid osmotic pressure is the inward pulling fluid. So these are the two main pressures. Now, how does the interstitial fluid osmotic pressure work? Remember, osmotic pressure has to do with movement of water. Okay, I want you to stop and think of this for just a second. Movement of water goes from an area of high concentration of water to an area with a lower concentration of water. One of the main things that's going to help you with this movement is the amount of proteins. And the amount of proteins is much higher in the blood because you have albumins and fibrinogens and all sorts of globulins and immunoglobulins than you do in the interstitial fluid. All right, so because your interstitial fluid is deficient in proteins, the movement of water, the movement of the osmotic pressure is from your tissue fluid, where it has, let's say, a concentration of 98% water, into your blood, which might be 70% water. That's the main movement, okay, that you're going to see with osmosis here. Okay, so these two pressures that I just mentioned, hydrostatic pressure and the interstitial fluid osmotic pressure, are opposing pressures. So they're going opposite of each other. One is going out into the interstitial fluid, the other one's going in to your blood. Okay, so these two are constantly fighting against each other. Now, hydrostatic pressure, we're talking about blood pressure, is only going to come into play on the arterial side of your capillary bed. Because once your capillary bed spreads out all of this blood into a gajillion little itty bitty vessels, the pressure drops. On your venous side, then you are going to have very little hydrostatic pressure, and the main pressure you're going to see on your venous side is your interstitial fluid osmotic pressure. These two pressures do exactly what they're supposed to do. On the arterial side, you deliver things, right? It's called filtration, capillary filtration. Things move out. You deliver the nutrients into the tissue. On the venous side of your capillary, you're going to have the interstitial fluid osmotic pressure greater than the hydrostatic pressure. So you're going to reabsorb things. You're going to reabsorb the waste products into your blood. And so now you can move it out of the body. So these two are your main, and this, if you understand that, you are way better than anything. Okay? All the other ones are sort of secondary to that. Now, remember that in your blood, you have to have a certain amount of proteins that are going to help your osmotic pressure. So if you had a condition like hypoproteinemia, you're going to have a problem because your hydrostatic, right, your hydrostatic pressure is the same, but your fluid osmotic pressure is not going to drive the same way if you have low protein in your blood. So if there's low protein in your blood, hypoproteinemia or hyperalbuminemia, right? So albumin being the main protein, you're going to slow down the fluid osmotic pressure, and thus you're not going to have reabsorption. You're going to have edema. See, those are the things that we need you to understand. Right? I know that took a little bit on that, but that's a really important concept for fluid distribution. It just makes sense if you go back, rewind, draw a picture, and then you'll see it. All right, so we have other forces, right? So they move fluid from the interstitial compartment into the capillaries, right? So the capillary osmotic pressure, right? And then you have your interstitial fluid hydrostatic pressure, right? So notice inward pulling, right? And then the other one is outward push of interstitial fluids against the outside of the capillary walls. All right, so you can see here how they all interact, right? So you could see the intracellular compartment, that is your intracellular fluid osmotic pressure, your interstitial fluid osmotic pressure, your interstitial fluid osmotic pressure, interstitial fluid hydrostatic pressure, right? Which is, again, this is minimal. This is important, okay? This is important. So the capillary osmotic pressure and your capillary hydrostatic pressure are very, very important, right? Interstitial fluid osmotic pressure. Okay. So your fluid distribution between your interstitial and intracellular is going to occur by osmosis, right? So we're going to move, it's all about the movement of water, right? So the movement of water, right, is going to be able to permeate, right? So cell membranes are able to be permeable to water because they have aquaporin channels, but not electrolytes, because electrolytes are charged, right? So they usually have a charge. Water crosses the cell membrane rapidly to equalize particle concentrations inside and outside of the cell, right? So water goes to the higher osmolality, okay? So it goes from higher to the higher osmolality. So wherever is a higher concentration of stuff, which is going to have a lower concentration of water. All right, so water movement out of the cells occurs when particle concentrations, right, of the interstitial fluid become higher than the particle concentrations inside the cells, right? Water movements into the cells, right? So occurs when the osmolality of the interstitial fluid becomes lower than the osmolality of the intracellular fluid, right? So fluid distribution, again, is very, very important. Remember, concentration measured in osmolality, right? If it is higher, right, movement of water, if it's higher in the interstitial fluid, right, you're going to have a particle, right, the movement of water is going to be out to try to basically create an equilibrium, right? So then water movement into the cells is when osmolality of the interstitial fluid becomes lower than the osmolality of the intracellular fluid. So movement of water, remember, this is all osmotic movement of water. All right, so fluid excretion, right? We have urinary tract excretion, right? We have bowel excretion, right? And then obviously if you have diarrhea, you've increased your fluid excretion through your bowels, okay? And remember, diarrhea can become life-threatening, okay? It can become life-threatening if it is severe enough, right? It is definitely going to cause a change in our osmolality and our concentration of our fluids, right? And in exhalation, you're going to see it in your skin, both in visible sweat and insensible perspiration. And what's really cool is insensible perspiration. If you were to put your hand on like a slate tabletop, which works even in our labs, even though they aren't actually made of slate, and you just wait for a minute or so, and then you look at the little concentration of like fluid that has accumulated on the table, you can really appreciate, when you do that, you can appreciate how much fluid we lose, okay? Because you only did that for maybe 15 seconds or 30 seconds. And you can perceptibly see how much perspiration we have. And again, that's only for 30 seconds. So can you imagine throughout the day? All right. So then, and if you do exercise, obviously that is more perceptible, right? And then the amount of fluid excreted in the urine is controlled primarily by hormones. It's really important that you understand how all of these hormones work, right? So antidiuretic hormone, right? ADH, also called vasopressin. It is secreted by the posterior pituitary. It is going to affect mostly the collecting duct. And in the collecting duct, it makes more aquaporin channels. The deeper into the collecting duct that you go, okay, the deeper you go, so you're going towards your renal pelvis and your ureter, yes? So the deeper you go, the more fluid we reabsorb, okay? We reabsorb more fluid. So if you are not making antidiuretic hormone, then you're going to lose more fluid and you are not going to reabsorb it, okay? So I want you to understand that. Aldosterone, remember, is going to work a little differently. Aldosterone causes the reabsorption of sodium, and water follows sodium, usually in the distal convoluted tubule. The natriuretic peptides, atrial and brain natriuretic peptides, work opposite of aldosterone, right? So aldosterone works by reabsorbing sodium. So sodium, instead of you excreting it, we reabsorb it. And when you reabsorb the sodium, water follows. Aldosterone causes an increase in blood volume, which causes an increase in blood pressure. Your natriuretic peptides do exactly the opposite. Your natriuretic peptides are going to secrete sodium. They secrete sodium into your filtrate, which eventually is going to become your urine. And water follows. They decrease blood volume and thereby decreasing blood pressure. So aldosterone is used to increase blood pressure, as you know, because it's part of the RAS system, the renin-angiotensin-aldosterone system. And the natriuretic peptides work exactly the opposite. They are antagonistic, right? And then we have other minor hormones that are going to also aid in fluid excretion, but those are your three primary hormones, and they all start with the letter A, except for B and P. So A and P is probably the most important one. Right. So your ADH, it is synthesized by cells in your hypothalamus and is released. Remember, because the posterior pituitary is actually part of the brain. It's part of your neurohypophysis. So the cell bodies are in the hypothalamus, but the axons that release ADH are in the posterior pituitary. The factors then that release ADH is increased osmolality, right, of the extracellular fluid, right? So if we have increased osmolality, we want to increase the amount of water, right? So we can decrease the osmolality. Decrease circulating fluid volume, because then, remember, when we reabsorb sodium, water follows, we increase blood volume, right? And then pain, nausea, And then also physiologic and psychological stressors can also play a role in releasing anti-diuretic hormone. All right, so ADH, right, causes a reabsorption of water, right? So we reabsorb water, right, which decreases urine volume because you are reabsorbing the water back into the blood, right? And so it decreases fluid excretion. And it concentrates the urine because we're reabsorbing water. We're not reabsorbing all of the contents of your filtrate. We're just reabsorbing the water. Right, so if ADH releases decrease, you will have a polyuria, right? You will have a polyuria, right, that is of a metabolic origin. So we call that diabetes insipidus. So if you were to just decrease ADH, right, for no other cause, we call that diabetes insipidus, right? And remember, the word diabetes is a polyuria of metabolic origin. So you have two types of diabetes. You have diabetes mellitus, which is sugar diabetes, and you have diabetes insipidus, which has to do with ADH, or vasopressin. Right? Ethanol decreases the amount of anti-diuretic hormone that you make. So if you drink too much alcohol, right? Ethanol, alcohol, same thing. If you drink too much alcohol, you are going to urinate excessively and you will dehydrate. And the reason that happens is because you decrease the ADH. So you're not reabsorbing the fluid you're supposed to. All right, again, aldosterone synthesized and secreted by the cells in the adrenal cortex. Remember, aldosterone is in a mineralocorticoid. It is going to be released by your zona glomerulosa. Zona glomerulosa. Okay? It is the major stimulus for the release is angiotensin 2. Remember, you will release angiotensinogen from your liver. If there is a decrease in your blood pressure, and we have to increase blood pressure, renin will be released by your kidneys. Okay, so in like the glomerulus, you will release renin. Renin will cleave angiotensinogen into angiotensin 1. Then we will use a second enzyme. Renin works as an enzyme. We will use a second enzyme called angiotensin converting enzyme to convert angiotensin 1 into angiotensin 2. Remember, this enzyme is called ACE, A-C-E. Yes? And angiotensin 2 is a very potent vasoconstrictor. Vasoconstriction, remember, narrowing of your blood vessels is going to cause an increase in blood pressure. Okay, so the action of your RAS system is to increase blood pressure. And angiotensin 2 also is going to release aldosterone. The aldosterone is going to be released, right, from your adrenal cortex, right, from the zona glomerulosa of your adrenal cortex, and it is going to go to your kidneys where it will reabsorb sodium. Water follows, it increases blood volume, which increases blood pressure. Another thing that could stimulate the increase of aldosterone is too much potassium in the plasma. Potassium in the plasma. So we can balance it by increasing the amount of sodium in the plasma. All right, so it causes the renal tubules to reabsorb sodium and water, right? Decreases fluid excretion, but it's a different mechanism than ADH, right? When more aldosterone is secreted, urine volume is smaller, right? So decreased secretion of aldosterone causes a larger urine volume. One of the ways we can decrease aldosterone production is by taking an ACE inhibitor. Yes, so if you inhibit angiotensin converting enzyme from converting angiotensin 1 into angiotensin 2, you lower blood pressure. Okay, so these pharmacological agents that decrease blood pressure are going to end in prils, like captopril or lisinopril. It's a type of blood pressure medication. It is one way we can attack high blood pressure. All right, so ADH is like the tap water hormone. It dilutes body fluids. Aldosterone is our saltwater hormone. It expands extracellular fluid volume. Right, so you have two natriuretic peptides, right? A natriuretic peptide, which is normally released from the heart, and then type B, which used to be called brain natriuretic peptide, but it's also seen and it's also released from the heart. It is from the ventricular cells. So now we just call it B-type natriuretic peptide, right? Which when ventricular diastolic pressure increases abnormally, like in heart failure, right? So the natriuretic peptides, A and B type, oppose the action of aldosterone, but not as strong as aldosterone. Aldosterone is very, very potent, right? So they promote fluid excretion in the fluid by causing natriuresis, which is sodium excretion in the urine, right? So when vascular volume increases, for example, natriuretic peptides cause the kidneys to excrete excess fluid, right? So when vascular volume is decreased, the natriuretic peptides excrete less fluid and they reabsorb more fluid. I'm sorry, they excrete less fluid, and then the aldosterone might reabsorb more fluid. All right, so fluid excretion is very highly dependent on, right, blood pressure. So we have baroreceptors and glomerular filtration rate, right? So glomerular filtration rate. So glomerular filtration rate is intricately balanced to stay the same regardless of blood pressure. Okay, so remember, go back and review that if you don't remember. All right, so fluid loss through abnormal routes, right, may be a significant factor in altering fluid status, right, in things like throwing up, right, in tubes that might be attached to the GI tract, your other body cavities, right, in hemorrhage. So when you are hemorrhaging, you are losing fluid, tissue fluid, and definitely in hemorrhaging, you're losing blood and proteins from your blood, right? Drainage into fistula, wounds, or even open skin, or paracentesis, right, into other areas of your body, right? Extracellular fluid volume, much easier. Your body is gonna deal with excess volume much easier because you just eliminate excess volume than too little volume. So excess is fine, right, for the most part. Deficit is much worse. In other words, dehydration is much worse than you being crazy and drinking 3 gallons of water a day. Because what do you do if you are going to drink 3 gallons of water a day? You're going to excrete probably 3 gallons of water. As long as you have the time to go and excrete 3 gallons of water, so be it. However, you must excrete it. I don't know if you know, but there is this example that I use in my classes a lot. There was this contest one year, probably about 10 years ago almost, right? Where there was a radio contest for, to win a Wii. And you had to not wee, not go to the bathroom, to win a Wii. And so they made these people drink fluid, okay, drink, but they couldn't go to the bathroom. And the mother who won ended up dying because, actually, I don't even think she won. I think last time I looked at it, I think she came in second place, but she ended up dying because of this contest. Because too much excess fluid is going to get excess fluid, if it's not eliminated out of your body, is going to go into to your brain, and it's going to go into the cerebrospinal fluid. It's going to go into other areas that are eventually going to cause you to not. So she got extra fluid in her brain, and that actually caused her brain to stop being able to regulate all of her functions, and she passed away. Okay? You can look it up. It was fascinating, and I was just, that's the only exception to like too much fluid. You can drink as much fluid as you want as long as you go to the bathroom. Okay? Involves a change in the amount or volume of extracellular fluid. Also can be termed saline imbalances because they're disorders of isotonic salt water, right? So it's in the same concentration as the normal plasma concentration. So extracellular fluid volume. So volume deficit, right? So by removing too much sodium containing fluid from the body, decreases in saline in the same concentration as the normal extracellular fluid, right? And then condition also sometimes are going to be termed saline deficit, right? So uncomplicated extracellular fluid deficit, right, is when the sodium concentration, right, the serum sodium concentration in the blood is normal. The concentration of the extracellular fluid is normal. The amount of extracellular fluid is abnormally decreased. Okay, so this is uncomplicated. So you can see their decreased vascular volume, right? You have a decreased interstitial volume, but you have normal osmolality. Right? So where can this come from, right? This is going to come from some sort of removal of sodium containing fluid from the extracellular compartment. So GI excretion, renal excretion, or other losses, sometimes sequestration into a third space in your body, like ascites, which is accumulation of fluid in that fluid between your in your GI, right? Between your organs. Okay, so that's an extracellular compartment. Right, so what you see, right? Sudden weight loss, postural blood pressure decrease with an increased heart rate, flat neck veins, right? Or neck veins that collapse with inspiration when a patient is sitting upright or supine. The lightheadedness, dizziness, syncope, right? Oliguria, or small volume of concentrated urine if the kidneys are responding normally. So those are some of the clinical manifestation of volume deficit. Decreased skin turgor, right? Dryness of oral mucosal membranes, hard stools, sunken eyeballs, and you might see even longitudinal furrows in the tongue, right? In infants, the fontanelle, remember, which is that anterior fontanelle, the top one between your frontal bone and your parietal bone, okay, that one, which is like a diamond shape, will be sunken inward, and neck veins are usually not reliably assessed in infants, right? So some clinical manifestations of volume deficit, right? Sudden weight loss in a sensitive measure, right? So 1 liter of saline weighs about 1 kilogram or 2.2 pounds. So a person who loses 1 kilogram in 24 hours has excreted 1 liter of fluid or lost it through some sort of abnormal route. Not necessarily a reliable indicator for third spacing, because if it goes from one compartment to another, you haven't lost any weight. Okay, fluid volume depletion can also be detected with shifts in orthostatic blood pressure, and it could lead to something called hypovolemic shock, right? So if you go back to the shock chapter, chapter 20, you can see a little bit about what happens in hypovolemic shock, right? And that could be fatal if not treated effectively by fluid replacement, right? So volume excesses, right? So you have the opposite of extracellular fluid, volume deficit, right? The amount of extracellular fluid is abnormally increased, And then vascular and interstitial areas have too much fluid. Right, uncomplicated extracellular fluid excess, extracellular volume excesses, right, where concentration of the extracellular fluid is normal and excessive amount of fluid is present. Right, so you might see an increased vascular volume, okay, increased interstitial volume, but normal osmolality. So this is uncomplicated. Right, so this might be caused by an addition, right, or retention of isotonic saline. So sometimes termed saline excess. So like if somebody received the banana bag, for example, and maybe they didn't quite need it. Right, so excessive secretion of the hormone aldosterone causes the kidneys to retain saline, which also can lead to extracellular volume excess. Right, so usually this is often seen in heart failure, in chronic heart failure. Right, so some of the causes, right, excessive intravenous fluid infusion of sodium containing, right, isotonic solutions, or renal retention of sodium and water. So what are the manifestations of volume excess? You're going to have a bounding pulse, neck vein distension in an upright position. You might hear crackles in portions of the lung, dyspnea, and orthopnea, right? So it's different position causes a difficulty in breathing. You might see a sudden weight gain. You might see edema. You might see frothy sputum of pulmonary edema if it's quite advanced. In an infant, you will see the opposite. Instead of having a sunken fontanelle, you have a bulging fontanelle. Okay? A bulging fontanelle. And then the assessment of their neck veins, obviously in infants, is not very good. Right? So imbalances usually are disorders, right, of some concentration and not the amount of extracellular fluid. Right? They're called water imbalances. Right? So serum sodium concentration reflects the osmolality of blood, and it is recognized by abnormal serum sodium concentrations. So when you have a low amount of sodium, we call it hyponatremia,